Hi everyone. Good morning, good afternoon, and good evening to some of you. It is my absolute pleasure to welcome everyone across the globe to MotusAcademy in all our webinar events. My name is Peggy, and with me here today I have Jackson. We will be your host for today's session, Lower Limb Robotics, Intelligent Solutions for Gait Training.
Thank you, Peggy. Hi everyone, Jackson over here. A very warm welcome to our second webinar session. I am very excited to host with Peggy as we hear from 3 different professionals in various parts of the globe to share their perspectives on lower limb robotics and more specifically, the gait training.
Without further delay, let's welcome our speakers. Joining us on our panel today, we have our president of MotusAcademy, Prof. Robert Reiner. He is a full professor for sensory motor systems at the Department of Health Sciences and Technology, ETH Zurich, and full professor of medicine at the University Hospital Belgris, University of Zurich. His work focuses on the investigations of the sensory motor interactions between humans and machines, as well as the development of user cooperative rehabilitation robots, exoskeletons, and visual reality technologies. Prof. Reiner is the initiator and organizer of the Cyberplan, which was awarded with the European Excellence Award, the Yahoo Sports Technology Award, and with 2 categories of the Reimagine Award. Prof. Reiner has also published more than 400 peer-reviewed journal and conference articles, 20 book chapters, and he has also filed 25 patents. In addition, he has received 26 personal distinctions and awards. In 2018, Prof. Reiner obtained the honorary doctoral degree from the University of Basel.
Next, we have a true-blooded clinician, Professor Seng Kwee, a senior principal physiotherapist who has been working in Tan Tock Seng Hospital Rehabilitation Center in Singapore for the past 28 years. He graduated from the King's College of London with a bachelor degree in physiotherapy in 1994 under the Public Service Commission Scholarship. Later on, he obtained his PhD in neurorehabilitation from the University of Southampton in the UK in 2015. Currently, he holds a joint appointment as Associate Professor at the Singapore Institute of Technology, teaching in the undergraduate physiotherapy, occupational therapy, and nursing program. In addition, he has been appointed a visiting fellow to the University of Southampton. He is also a research scientist at the Rehabilitation Research Institute of Singapore, the RRIS. It is a joint research institute by the National Healthcare Group initiated by Tan Tock Seng Hospital Rehabilitation Center, Nanyang Technological University, and the Agency for Science, Technology and Research, the A*STAR. Being a passionate clinical educator, he is an active member of the education group of the International Industry Society in Advanced Rehabilitation Technology, the ISAT, contributing to the cause of creating awareness of the clinical application of rehabilitation technology.
Last but not least, we are also very honored to have Peter KREYNIN, the supervisor and the project manager of ExoAthlete Global. He has extensive management experience and expertise in setting up new projects as well as optimizing existing ones, specifically in the areas of rehabilitation robotics. He graduated from 2 departments of Moscow State University and then received his PhD in physics from the University of Newcastle upon Tyne in the UK. He has also worked as an invited researcher at the University of Chicago and the Enrico Fermi Institute prior to joining the ExoAthlete team in 2019.
Now, we have a good idea of who our speakers are. Let us get started. We welcome questions from the audiences. Please type them in the Q&A box below, and we'll try our best to keep an eye on them and get our speakers to answer them live. So first, let's welcome our president of MotusAcademy, Professor Robert Reiner, to share his presentation.
Thank you, Jackson. Thank you, Peggy, for introducing me. And I'm very happy to speak to you now as a function of speaker and researcher in the field. So my focus today is on our approaches of robot-aided gait therapy. So I'm focusing on lower extremities. In my lab, we have a lot of other activities going on in collaboration between two large facilities. That's the ETH Zurich with a lot of technical competences, and the University Hospital Balgrist, where I have direct contact to the physicians, to the patients, and clinical experts. So large an important patient group are patients with hemiplegia after stroke. And there are many cases every year. It's around 60 million cases in the world. It's only in China, it's already more than 1 million cases every year. Unfortunately, many people die, but others who survive, about half of them are suffering from different kind of plesias, especially hemiplegia. And the result, of course, is in the acute phase that they're hospitalized, that they have to spend a lot of time in bed. Physiotherapy and occupational therapy are important to start in an rather early phase. However, time is limited, and roughly only maximally 10% are spent to train the body, to therapy the body by applying physiotherapy, occupational therapy, or speech therapy, and so on. Most of the other time, people are sleeping, eating, maybe talking, watching television, and which is also maybe important, and they cannot do the training all the time, but 10% is too little. We have a much larger potential to learn and improve our body functions due to training. We know it from children, and they are very intensively training. And if you're less than 12 months old, not able to walk yet, these little babies are doing up to 26,000 leg movements while lying supine. Then when they start to run, they are doing about 14,000 steps per day. That's a lot. I mean, in our daily office work, we do not get this high number of steps. We have to go hiking or running to apply such a high intensity of training. In patients after any kind of lesions, we have to also get to these high intensities to exploit the neuroplasticity of the brain. And for this, machines can help. There are many machines for gait training. For example, such machines as you see here, which are all end effector-based approaches, where the end effector of the machine, so the final segment of the moving robot or moving machine, is connected to the foot or the lower leg. And then the people can do some kind of gait, typical or gait-like movement. There are also other devices which are exoskeletal based. Here, a skeletal structure is connected to the human leg with the joint axis of the robot in alignment, possibly in alignment with the joint axis of the human body or leg. And there have been also many clinical studies, several hundred clinical studies, where these kind of mechatronic devices or robots are applied to human in gait rehabilitation. And Jan Meerholz et al. Did publish a meta-analysis about many of these studies. They included 62 different trials with more than 2,400 participants or patients. And these participants did receive this kind of electromechanical, you can also call it robot-assisted gait training, in combination with physiotherapy after stroke. And what they found out is that these patients using such kind of machines are more likely to achieve independent walking than people without using such devices. But even more importantly, what they also figured out is that patients after 3 months after stroke, so within this 3 months after stroke, and those who are not able to walk seem to benefit most. And that helps you to understand some of the results which might appear contradictory. There are some papers, for example, using the Locomat device, a famous gait training robot, saying that the application of this robot does not benefit the patients. If you see some of these results, they're probably true, but check out the kind of patients. These are often then patients who are already ambulatory. If you can walk already, or if you're in a chronic stage of the rehabilitation, then you might not have a benefit from this kind of training. So it's very important what kind of subjects you include in the studies, and you want to improve or apply such kind of technologies in the rehabilitation. Just mentioned the Locomat. It's probably the most successful device developed in Switzerland, not by me, but by colleagues at the company Okoma. And it's an exoskeletal device for gait training with a screen to add some instructions and virtual reality. And we in my lab have used the device to develop several additional strategies. So we added a patient cooperative control strategy where the patient is not guided like in a position controller, but they are allowed to do some variations from a desired physiological gait pattern. So they can deviate from a gait pattern and in this way have a stronger learning effect. There's a larger variation from step to step, from period to period of gait, and they are also forced to participate to the movement. So they are not passive. They have to actively contribute to the movement, and that is allowed by this kind of a special impedance controller, as we call it. We also do other research. Just to give you an overview, we developed also a special device, a gait trainer, where people can walk in the MR scanner. Since the MR scanners are made that you have to lie, we had to build a device which allows you to walk during a lying supine position. And that machine resembles or copies trajectories which are similar to Gait by two pneumatic cylinders that are moving the leg, and two more pneumatic cylinders are attached to the legs to produce a ground direction force to the soles, to have this kind of kinetic experience people have during walking. And the process going on in the brain can then be watched in this MR scanner. And this was used together with colleagues from our hospital to better understand the processes going on in the rehabilitation of people with after stroke, for example, and how the rearrangement of functions in the brain is taking place in the longer phase of the therapy. So here, you see, for example, you see some differences between active and passive leg movements, which are plausible, of course, but of course, we could also look much more carefully and much more in detail into the processes going on in the brain. Back to the Locomat, here it's also important that the people are motivated, that they are training, that they're not bored, that they want to come to the training, that we get a good compliance. And when they come to the training using that kind of robot, that they also are motivated, that they're participating, that they're engaged in the movement and not too passive. Activity is very important to have a stronger neuroplasticity effect. And activity can be promoted by visual cues, by auditory cues, by tasks which they see and immediately understand. When they see this trial and obstacles, they know they have to lift the leg to get the foot over the obstacle. And we have developed many different games, also soccer games for the pediatric version of the Locomat, where people can now play soccer against a virtual opponent. And the children are very motivated and they're actively participating to that movement. What is important here is really to say that we do not only move our body from a physical point of view, but that we are also engaged, that we have a cognitive activity, because this can produce stronger neuroplastic effects. So we need a strong engagement from the cognitive and physical point of view, because there are actually two reasons. One is that the people are just there, that they are, by this visual cues, they want to participate. They are motivated to participate. They are not staying at home. They are motivated. And secondly, more processes are going on in the brain. More dopamine is released due to this kind of multi-stimuli which are acting onto the body or onto the brain. And this is another reason why there might be a stronger effect when this kind of games and virtually assisted tasks are implemented. The challenge here is, however, to provide the right level of engagement. If we stimulate too much, if the task is too difficult, it might also have a negative effect, demotivating the patient too much. So what the training is being done here is the following. There are several cues which we measure. Sensor information which we measure in the device. These are biomechanical recordings from the sensors, from force and position sensors in the device. We feed them back so that we can change the scenery in this kind of setting. We can change mechanical stimuli in the machine by producing more force, more guidance, more friction, faster speed of the treadmill and so on, but also by changing audiovisual cues to have an effect to the motivation. But how can we close the loop to get the right level of motivation and engagement? That's by measuring also psychophysiological recordings, doing some machine learning to let an state estimator then choose about the right rendering parameters or variables. So we can change now the scenery and the task in a way to always keep the patient in the right level of motivation and avoid overstress, but also boring situations with too little stimuli. Here's how it can look like. One of the sceneries, you see a nice environment, but now we can change the weather to produce some arousals. We can even produce now lightning and the thunder to kind of wake up the patient. Now they see a bridge in a canyon. We can change the depth of the canyon in a continuous way. We can even change the width of the bridge to make it more exciting. And if this doesn't help, we can start the bridge to sway to make it more, to produce more arousals of the patient. Of course, we do not want to frighten the patient, but the children, for example, like it a bit more with action. Then we have to go to higher, stronger arousals rather than with maybe old people where we do it more carefully. Now jumping to another product, that's a device which is used for patients in a more acute phase when they're still bedridden. And in this early phase, you can already move the legs while verticalizing the body to not only stimulate neural functions, but also cardiovascular functions. What we developed in several PhD theses in previous years is we programmed an algorithm which allows the patients to control the patient's heart rates, and in some cases, even the systolic and diastolic blood pressure. And here we measure heart rate and blood pressure, and in a rather continuous way, or in a short discrete distances. We have reference values given from the clinicians. The heart rate should be just normal, maybe 50 or 60 beats per minute. And the blood pressure should also be not too low, but also not too high. And then we can change the inclination angle or the stepping frequency or functional electrical stimulation to keep the heart rate and the blood pressure in the right level. This was about training or therapy devices. Our field of rehabilitation robotics has also another large area. That's the use of the robots for daily life, for getting more mobile, for assisting in daily life, but also to use it as a mobile device in a therapy unit. So there are many more mobile devices like Andago or like Exomotos from Full Intelligence, which allows people to walk in a more free way, to walk on a corridor, or maybe even walk outside or in home environments. There are exoskeletal devices from other companies like Rewalk, for example, developed for both for therapy in hospitals, but also for daily life assistance. And that's one, or this was the first device that was released by FDA to be sold as an assistive device in 2014, I think. There are many other companies from all over the world. Rex Bionics is from New Zealand, Parker and Exobionics are from the States, Honda from Japan, as well as Cyberdyne. And there are many more devices which are currently now in the research labs. And now it's a trend that devices are getting more lightweight and softer. They're easier to apply. The forces might be limited still, but the wearing it and the putting it on is much easier. And our approach in my lab is to really develop one of these devices with the goal that it's just lightweight, but it's not there to get rid of the wheelchair. People are still sitting in a wheelchair, which is a great device, rather cheap and convenient if the ground is even. But if there's a little step, then they can stand up, walk inside, say hello to the people inside the store on an eye-to-eye level, being able to grasp something out of a shelf, which is higher, and then they can walk back to the wheelchair. So we thought it doesn't need to be powered too much. Most patients are anyways not completely paralyzed. And so we thought about a very simple device saying we try to use only one motor per leg, but not to drive one joint only, but to drive several joints in a coupled way. So these joints are then not independently controlled, but still we try to make it very simple by using a rope system and by exploiting joint synergy. So that's the idea of using one motor for several joints, but in a way that it's physiologically meaningful. And we found a gait phase, which is indeed inviting us to apply it. That's the beginning of the stance phase, the first maybe 30% of the stance phase, where we have to produce a lot of force in the gluteus muscles and the quadriceps muscle to work against gravity. Otherwise, the body is colliding in that important phase of the gait. So we provided a support of these anti-gravity muscles by using tendons which are acting behind the buttocks at the gluteus and in front of the knee joint. And that is the way how the tendons were roped. On the left, you see that they were going from the pelvis behind the hip joint, then going to the thigh in front of the knee joint, and then to the ankle. But at the ankle, we do not provide a joint to talk. And we developed this device. We formed a company called MyoSwiss. And that was the first version of it, not sold. But in the meantime, we sell a version which is looking similar to this one. We see again here now the motor is in the backpack. It was not the case at the beginning. We use several sensors, inertial measurement units, and position sensors to measure the length of the rope, to have some feedback signals. We also developed an instrumented crutch where we can measure force. And that's a very important signal, because that helps us to rate how much force can be taken over by the device. How much force does the patient still have to apply through the arms and the crutches, which we want to minimize actually. So we did many studies in patients and healthy people. We could show that using the device, you see it on the right-hand side, allows faster gait patterns, fast enough to go over a street as long as the traffic light is green for the pedestrians. It was significantly faster, relevantly faster. That patient could even participate in a Zurich marathon for a distance of about 8 kilometers in a walking pattern, but that's still great because he was not able to walk that long distances. He usually needs a wheelchair. It's very fast and easy to put it on. I will cut this movie now, but it takes, I can tell you, it takes less than 2 minutes, even for the beginner. The right picture is not a therapist, but a student who is one of the first times putting this on to a subject, and even for her it takes just about 1 minute. So up to last month, there were 750 patients who were tested with this device. 3,700,000 steps have been performed by different patients using that device, because the steps have been counted in the computer of the device, and 17 different kind of pathologies were so far treated with this device, all over the devices which are sold in Germany, Switzerland, Benelux, and Italy. And the last application now is the most recent application is to use it also for patients in cardiovascular disease, where they have the problem that due to heart failure, people don't move anymore, they don't walk anymore. And in this way, the body gets further deconditioned. And we want to break them out of this loop by allowing them to train a little bit, by moving, by walking, using the device. And in this way, allow a conditioning of the body, and in this way, avoid or reduce fatigue and dyspnea, so that the respiration is too little. That's just a movie from our collaboration partner, from the Clinic Charité in Berlin, where now 20 patients have been treated in a pre-study with the device. And now they started the second phase study, where we try to show the effectivity of that approach in that kind of patients. With this slide, I'm finishing now. I wanted to, the final take home is just that the devices we are developing can be used for both. I mean, the mobile devices can be used for both, for clinical therapy, as well as for home use and daily assistance. And with this, I want to thank you, and I'm ready for questions.
Thank you, Professor Reiner, for sharing your presentation. It is really true that neuroplasticity is such a huge topic in the neuro rehabilitation, and it takes the engagement of physical therapy and also the cognitive training to actually show the neuroplasticity effect. And here we can actually see how the integration with the VR into rehabilitation helps to motivate the patients while providing the effect of neuroplasticity. And also we do see some great interventions such as the MyoSwiss that you just showed us. And I hope this really inspire all the inventors out there to look forward in the near future.
Right. Moving on, let's welcome Prof. Kwee from Tan Tock Seng Hospital Rehabilitation Center to share his presentation on the clinical aspects of utilizing lower limb robotics to enhance patients' functionality and quality of life.
Thanks, Peggy, for the kind introduction. Firstly, I'd like to thank MotusAcademy for this invitation to share with you the clinical perspective on the usage of low-limb robotics. So as what Prof. Reiner has already mentioned, robots can perform tasks that humans can't. That is to provide a very high intensity, high repetitions, and task-specific training for the individual with disability. And just to give you some sensing of why we need to integrate robots in our clinical setting, if you look at a conventional physiotherapy session, this observational study has picked up that a patient gets to practice up to 100 steps in half an hour therapy session. However, with robotic system, patient can practice up to 1,000 steps in half an hour of therapy session. So when you look at these numbers, obviously the high repetition can help to induce neuroplasticity and aid patient in their recovery. And I'm really delighted through numerous years of basic sciences and animal studies, we have truly seen the transformation of such robotics in clinical setting. So Locomet is one of the earlier systems that many clinics worldwide have been using. So let me share with you videos of various Gait trainer systems like the auto ambulator, as well as the local help here. So I think, as mentioned, there are different exoskeleton out there, and this is from Israel called the WeWalk. And again, the motto is strong enough to assist someone to climb up and down stairs. And 4D Intelligence has also come with their own exoskeleton. And it's beautiful with this video showing the potential of people with disability using such cutting-edge technology to go out and participate and socialize with their friends and families. Next up, this is one of my dreams to help children with disability. And it's so wonderful to see the Spanish group who came out with the Atlas 2030 pediatric exoskeleton. So you see a child, I hope you're still hearing me okay. Is this all right, Peggy?
Yes, it's still all right.
Okay, okay. Yeah. So with such exoskeleton, I think it's so nice to engage the kids to enrich their lives. And I also like to congratulate Excellent for coming up with the Bambini. This exoskeleton for the pediatric population, again, will encourage them to be upright, to be active, and going out with their family and friends. And I was really impressed with this. Excellent Bambini Mini. It's so cute. You know, even little child with disability can be supported to be upright and continue their growth in a more with a more erect trunk. So I really like to congratulate Peter and your team for such wonderful works. And I believe that introducing exoskeleton early in a child's development is so critical, right? They're improving their posture and looking beyond walking abilities. I also want to consider their bowel bladder function as well. So from Canada, you have the Trexo Robotics, and they came up with this exoskeleton integrated with a rollator frame that can help a child to feel safe as they are training to be up and about walking to explore the environment. So again, all this improve the quality of life of children with disability. And in this publication, it's really interesting to read it in detail because this child was really unable to stand and walk. And why is it that exoskeleton was introduced? Intensive rehabilitation was provided, and after intensive 12 weeks of training, this child actually showed improvement in the bowel movement, right? So I highlighted this study to encourage therapists to look beyond just locomotor goals. You've got to consider other goals as well, such as bowel bladder, as well as targeting the spasticity, because exoskeleton has been shown to reduce spasticity after intensive training. So what's the evidence for lower limb robotics? So thanks to Professor Reiner, he has already talked about this important Cochrane review. I won't go much into it. But other studies have clearly shown that the exoskeleton not only improves mobility, it helps to improve trunk control, bowel bladder function, as well as reduction in pain, as well as spasticity. So these are important goals for therapists to consider. And numerous MRI studies have shown that with intensive robotic therapy, it helps to increase the cortical activation in those parts of the brain responsible for locomotion. So very nice study by Korean side as well, that in the robotic group, with the intensive training that they receive, those individuals actually shows increased cortical activation. And in this study, they also compare if they start the robot therapy earlier versus later, those individuals in the earlier robotic therapy group actually performs better as well. So again, encouraging therapists to consider robot-assisted therapy early on in the rehabilitation journey of patients. And this nice systematic review has also lent support to the usage of exoskeleton to improve their quality of life. So if you scan the QR code, you can access this full text because it's open access. Next, I'm going to show you videos of my patients that have gone through the exotherapy session and highlight some learning points. Over here, we have a young stroke patient and who undergo conventional physiotherapy, and when exotherapy was introduced intensively 5 times per week from Monday to Friday, you can see that he practiced numerous number of steps from this screenshot of the exo. And just after 5 sessions of exotherapy, it's amazing to see the change in his symmetry of weight bearing when he stands, as well as when he walks. And not only that, there's increased hip flexor activation such that he can swing his leg much better without the need for therapists to kick his leg. Next, a case of traumatic brain injury. This gentleman exhibits severe trunk as well as lower limb ataxia. But when we strap him up into the exo, of course, he can't be moving his limbs around with ataxia, and that actually forces him to walk with better posture. And let's have a look at his result after 15 sessions of exotherapy. You can see a significant reduction in the amount of trunk as well as lower limb ataxia. So it is indeed magical to see such a change after a very intensive training. However, having robotic therapy is one thing. We mustn't forget that after robotic therapy, there's a need to train the balance as well as overground ambulation. So combining the positive gains from the robotic therapy and with conventional physiotherapy, this gentleman eventually was able to use a rollator frame to walk around, hence making it easier for the carer to support him and walk. Next up, a gentleman with transverse myelitis. You can see that when adopting a conventional physiotherapy approaches, it requires 3 therapists with the help of a Seng hoist to ensure his safety to actually move his limb step by step. But with the exo, this gentleman can walk very freely and enjoy the training walking around our garden in the rehab center. And after 25 sessions, it was amazing to see the increased motor return in his lower limbs, such that he can start to use a walking frame to walk around. So having seen that positive gain, I took him through another 15 sessions of the EXO. And at the 40th session, he had one wish that he wished to push himself and walk further. And in that 40th session, it's truly amazing to see that he actually walked non-stop for 1 hour, 55 minutes. And yes, he actually broke his personal best record, and he walked non-stop for 2.6 kilometers. Again, this highlights that it is something humanly impossible to walk somewhere with this level of disability, and robotic therapy can provide the solution to help these individuals. So after 40 sessions, it's so nice to see that this gentleman was able to use a quad stick to ambulate around. And more recently, before the end of the year 2021, this gentleman was gradually able to use a quad stick to ambulate with only occasional contact guard from the therapist. Again, this illustrates the positive outcome after robotic therapy. Next, a case of multiple sclerosis. We got this case report published in a high impact journal in Multiple Sclerosis Journal. So scan the QR code and have a read if you're interested. So this is a 51-year-old lady with progressive MS, and gradually she did regress so much that she was confined to a wheelchair, unfortunately, at EDSS 8.0. So essentially, she couldn't ambulate. So when she goes out with her family, she needs this eTech Turner Pro to help her with the transfer. And because of the hassle, she was very reluctant to go out with her family. So the aims, after assessing her, I discussed the goals of the therapy with her, and we came up with such an aim of using EXO to improve her trunk control, her lower limb strength, as well as improving her cardiovascular fitness and her mood. So she went through an intensive 15-session therapy twice a week, and each session lasting an hour each. So let's have a quick look at the result. There was no adverse event. And after 15 sessions, she was quite amazed herself that she clocked a total of 6.6 kilometers. Her film score improved, and she was able to transfer with ease with her husband and helper. Now, what I wish to highlight here is also her EQ5D score. You can see from this slide that the change exceeds the MCID, and it's really amazing that it has changed her life. Let's have a look at her report. She shared that being wheelchair bound for 6 years has me yearning to walk again, and now such exoskeleton has given her hope. And psychologically and emotionally, it helps to boost up her confidence, her self-esteem, such as she's more willing to go out with her family. There's also improvement in her quality of sleep. And that actually improved her participation in the community and hence better quality of life. And what's really unexpected was this. Previously, she was reluctant to go out with her family, but now with her improved mood, improved self-esteem, she actually encouraged her husband to do brisk walk with her as she motorized herself in a wheelchair to get to the nearby shopping mall. So interestingly, that got her husband to be more active, and it's amazing to see through this case that such robotic system has helped to improve her quality of life. And just like to share this delightful news that she's a lady who managed to clock the first 1 million steps using our EXO, and that was verified by EXO Bionics that we are the first in the whole Asia Pacific to achieve that. So although this is 1 million steps, it's just not about the numbers. It is about people with different disability receiving benefits from such cutting-edge technology, step by step, to retrain their locomotor function, improve their trunk control, and improving their quality of life. So I think Peter talked about BCI technology. And it's wonderful to see this breaking news way back in 2019. So if you're interested to read this paper, scan this QR code and download the full text. Now, so this gentleman with C4, C5 spinal cord injury had this implant in the brain to help to detect the EEG waves to activate this exoskeleton. And in this video, you can see that there's a ceiling hoist to ensure the safety of this individual, and the signature EEG waves are processed in order to activate the exoskeleton. So really, this is very promising. So I believe in the near future, and this is my dream, to actually see wireless BCI to activate robotic exoskeleton. So I want to congratulate Fourier Intelligence for already working on this. So in this video, you can see someone wearing an EEG cap and using the EEG wave to activate the exoskeleton. That means when the person think about walking, moving the right leg, the exoskeleton will move the person's leg. So it's very, very powerful technology. And I believe in the near future, we will have a full exoskeleton suit for people with disability, right? Controlled by brain-computer interface, because as the person think about it, mental imagery takes place, and hopefully that can activate the upper limb or lower limb exoskeleton. So we hope to see more of such people with disability out in the community enjoying life. And this is what I envisioned it to be in the near future with such robotic technology. So with that, thank you very much for your attention, and I'll end my talk here. So I'll be more than willing to take questions from the audience.
Thank you so much, Prof. Kwee, for sharing the diversified clinical cases. I would think it was really impressive to see how robotics rehabilitation has changed so many people's lifestyle. And we are also very looking forward to see more clinical studies, especially in the pediatrics group, because that will be something that is interesting to know about, especially, you know, now that we have this Bambini from Exo Athlete, and also a lot more manufacturers who are also working in terms of pediatricians rehab.
So let's welcome Peter from Exo Athlete Global to share his presentation on lower limb robotics.
Thank you very much, Jackson and Peggy, for inviting us here. It's a pleasure to talk to you and to present it all. I will probably have the most general presentation because we come to the stage of robotic rehabilitation from a different perspective. Since we are developing the devices and we try to make them as universal and as useful for every user to be able to later use them in any way they need to, such as Professor Reiner, who needs it in more research environment, or Professor Kwee, who needs it for purely theoretic, for purely rehabilitational, as a purely rehabilitational tool. So let me start with a basic background where we see ourselves, and then we will slowly come to how we proceed from there and what it results with. So let me start with the most general question. What's the ultimate goal of rehabilitation as we see it? And I really appreciate the input from the colleagues, especially from Professor Reiner, who said that basically there are two parts of it, and which means we're not alone on this route. There is indeed physical rehabilitation, which basically is restoration of the capabilities of a patient, or getting him at least as close as you can to what he could do or what he should do. But equally important is a mental or emotional part, which which basically means that the patient needs to be involved into rehabilitation as much as possible. And without this, pure movement is not as close as efficient as it is when the patient really needs, well, inputs into his or her rehabilitation. So what do we see wrong in the physical part of the rehabilitation, and why to use them? The first answer is, of course, you can get faster results because our aim is to take the load off the therapists, physical load, I mean. Most of the therapists are, well, some of them are nice and cute girls, and what we see is they sometimes may struggle with the patient when the patient is like big, huge, bulky guy, and the physiotherapist is a beautiful, like 50-kilo lady, and she's saying like, what am I supposed to do with this? Of course, there are tools, there are ways to take the load off physiotherapists, but why not help them get faster and simpler results? And also an important step, which has been become available recently, is robots do help to get the patient as close to the, well, normal state as possible, which was not available possible before introduction of the robots. Of course, conventional physiotherapy exists for years, but what we figured out is that combining conventional therapy with robotics gives you a lot faster and a lot better results than when these are separated. And I'll come back to this later. How do we combine the two? This will be a point for a little bit of further discussion. But coming back to mental rehabilitation, that's where we're still behind, because in terms of robotic rehabilitation, that's not yet where the robots can do much. Thanks to the colleagues, they do refer to virtual reality, to all these kind of interaction, but still there's little to compare with emotional interaction with the doctor, with the people. And what we do see is that a lot of our, well, we try to call them pilots, because since we are talking about high-tech stuff, it's not like being a patient, it's more like piloting the exoskeleton almost like a spaceship. It's not as complicated as that, fortunately, and that's another goal of us, to make it simple. But these people do have a lot of emotional requests to rehabilitate, to stand upright, to look at people horizontally, rather than from below, from a wheelchair or from a couch or something like that. So we do see this as a very important step in rehabilitation, and we do really want to, for robots, for our devices, to help in this as well. So the question stays, where are we at the moment? If you look at the pictures, these are simply two photographs of the first spaceship which took the man to the space, which is Vostok 1 on the left. And well, I'm sure you all are aware of the Crew Dragon, which was launched a couple of years ago. And you see enormous difference between the two. And if you think about this, this is only like 60 years between the two. So I would not like to say that we are closer to 1961, of course, in terms of robotic rehabilitation. Fortunately, the technology has grown so that we're probably pretty close to 2020. The devices have become more useful, lighter, user-friendly, and easy to use. Of course, there's a lot to do, but you never know where it stops. The space travel was required a lot of preparations just a few years ago, and now it's almost like a tourist trip to the other part of the world. So I would say we're pretty close to being able to introduce this already to quite a lot of clinics, rehab centers, and even homes. And people should be able to use them easily and freely. And as long as we're talking about interaction of people with robots, let me quickly remind you about the famous 3 laws of robotics. And in a sense, the challenge we face as developers of the exoskeletons is that we are, in a sense, if not breaking, but bending the rules. For example, if you think about the first law, a robot may not injure a human being. Of course, we're not talking about injuring a patient, but we are pushing him a lot further than he is able to at the moment. And training is always about pushing the boundaries a bit further. The second law says it needs to obey the rules and until it conflicts with the first law. And yes, this brings a lot of safety issues where the exoskeleton must stop if something happens. We're talking about spasticity here. We're talking about the physical abilities of the patient. And that's where basically we need to do a lot of background work so that the users, Professor Kwee, and all other users, you, our audience who's going to use this, need to not think about the backstage of the process. You just need to be sure that it's safe, that it's working the right way. So we as engineers and developers took the burden of designing it in a way that it fills the gap between what a person can do and what the person needs to do. Fortunately, the robots are not yet as smart as to talk about the third law, so I'll avoid that. They're not protecting themselves at the cost of human life. So fortunately, we're not at this stage yet. So all this, we're not creating a Terminator. Once we get there, we'll definitely take care of that as well. So the big question is now, will a robot replace a doctor? And in our understanding, here in ExatLab, no, it will not. Not in the foreseeable future. So we're not replacing a doctor and we're not making it obsolete. Although it's very tempting from any perspective to take a human being, an injured human being or an ill human being in terms of whatever, cerebral palsy, for example, put him into a machine of some sort and take him out after some time completely cured. That's not the case. And that's why we think that so far what we're talking about is the human and robot interaction. There always needs to be a doctor or a physiotherapist or even a member of a family. It does not necessarily need to be someone overqualified. We do not need a professor, university professor to accompany every injured person. And that's another goal of us, to develop something that is easy to use and that can be easily trained for so that the patient is feeling comfortable and that the doctor is feeling confident that the training will take the patient to the place where they want to be. With all that, we even have the so-called non-rigid list of contraindications, which may be confusing for some doctors, but basically these are 2 lists. One is an absolute contraindication, like a broken bone, for example. There's no way you can override that, but there is the list of relative contraindications. For example, the spasticity level. We officially say, okay, you can use it up to level 3 of Ashworth scale, but that's only our expectation. If the doctor and the patient believe that this particular patient in this particular case is able to be trained in this particular mode, fair enough. You take charge of that, you do that, we provide you with a tool. So coming to the practical side of it, that's the background we used to develop what we developed basically. And we decided to concentrate on lower limb robots. And I'm glad to actually see that It's known that Professor Kwee has referred to it, and I'm sure Professor Reiner may remember our involvement in Cyberthlon for a few years now. So it's a close community. We all work together, and we do believe that this is a fantastic time for us all to start developing this, to start introducing the robotic devices to the world, to the university communities, to rehabilitation communities, because we've reached the stage when they are easy to use, they are safe, and they are not bulky anymore. They basically can be used after less than a day training. We concentrated on neurology first, and that's where you can see all the indications like cerebral palsy and spinal cord injuries of different sorts, and stroke, of course. But the reason we have a standing alone arthroplasty is that it basically proved the theory that if you're doing something right, it works right in all senses. One of our colleagues said, and came to us and said, look, people are so much used to walking improperly after the replacement of hips or knees that even after the replacement, they're still limping. So why not retrain them to walk properly? And it has nothing to do with neurology, as you may see, but it worked. So this probably means that the applications we're thinking of in terms of robotic rehabilitation are just a minor part of the big area where they can be used. So we may not even think of something. Maybe they will fly to the moon someday. We're open to that. So as engineers, we face a few issues in terms of usability of the devices. And that will probably be an answer to many of the questions which may arise later. We try to make it as simple as we can without overloading the doctors, the users, with too much options. What we figured out is that as long as we offered all parameters to be adjusted, well, it didn't work. Basically, we realized that the doctors are simply using it at some average modes and use the exoskeleton in this setting rather than adapting it, fine-tuning it to every patient. It's still possible, but we would rather make it simple and reliable for the users. This is why we try to get rid of the cables. So there's no need to recharge it. There's no need to have all the cables between the control devices, and even the patient can use it and control it himself with a crutch when he's trained enough. And that's what has been shown in one of Professor Kwee's video. Loads and loads of different modes to suit the needs of the patient and the doctor. The exoskeletons need to be initiated by the doctor or by the patient themselves if they have any remaining ability to move their extremities. Of course, you can adjust the level of support and so on and so forth. And all these tools can basically be taught to train in less than a day. And this is, I think, the biggest challenge of most of for most of the developers. We can create very sophisticated devices, but if they're not useful, what's the point of that? So next steps, what we plan to do, and again, I'm happy that it goes along the road of general anticipation of the robotic development, like the colleagues from ETH Zurich suggested. Of course, we do need to imply a lot of other control modes, like brain-computer interfaces, which are working already. There's still need to be fine-tuned, but that's the way to go. Virtual reality, of course, and there's a lot of work going on, which has been described as well. Also, there will be a lot of work with machine learning and big data analysis, so that the machine can also take some work off the doctor to determine what are the capabilities of a particular patient. That's an ongoing work. I need to reveal a secret. Of course, there's a lot of work going on there. We're working on that as well, and let's see who comes with the best results. We can compare it with the ETH Zurich and other teams who are, I'm sure, working on that as well. So let's have a fair competition. And of course, there's a lot more behind this, because this is a very complicated device. So we are also going to simpler options like assistive devices for elderly people, for industrial use, which do not require to move a paralyzed or hemiplegic or paraplegic person around, but they're simply strengthening and taking the load and the troubles of spinal cord injuries from the users, from the workers. So, of course, there's a lot to do, but finalizing my presentation, we see the modern world at the stage of already developing the devices which can be used widely. So the market is open. The market is quite free at the moment. There's just a few teams working on that, so there's place for everyone. So once we join the efforts, I'm sure we can make the basically the whole world happy and safer place with more and more people returning back to normal life. So, well, thank you very much. And before I leave the table to Professor Wee again and Peggy and Jackson, there's one thing I forgot. There's one vitally important thing which has not yet been mentioned, but it's an absolute must for all rehabilitation. Without it, nothing will happen. So that's it. Thank you all very much. I'm sure with all that, we'll take rehabilitation and our work much further. Thank you very much, and hope to talk with you. And please feel free to ask any questions.
Thank you, Peter, for sharing from the industry's perspective. The advancements of rehabilitation robotics has helped people to reconsider the current physical limitation and also redefine new life standards. We hope that the technology will continue to advance and the innovations will help to empower the clinicians and patients around the globe.
Thank you so much for staying with us. And there are a couple of questions in the Q&A session that we think we should also share with everyone. So let me pull up the questions. So there's one question here by Alex. So the question is, with assistive devices like soft exoskeleton, the objective is to bring it to the patient's home. So far, most of them are in rehab facilities. So what is the strategies to bring it to the patient homes as in a first step? So lowering the price, or be it like bring it to a level where it is getting reimbursed by insurance. So Prof. Reiner, Prof. Robert has already answered it. So Prof, do you want to take it, or?
Yes, I'm happy to say what I wrote as an answer. So when the patient is ready to, from the physiological or medical point of view, to transfer the training to home environments, or to use as device to assist that person in daily life, then it's good if we have devices which can be used at home. But for this, we have to change technology still. Of course, the technology must be affordable, but that depends also on the healthcare system, because sometimes insurances, not only health insurances, but also insurances who take over costs for living or for working, can take over costs, and often devices don't have to be bought, they can be rented or paid with monthly fees. But what is more important is that the technology is useful for the people, that they're able to use it, because they are physical disabilities or impairments, and or they are older people. So it's not so easy to put it on and to use it and to operate it. And the modes how to operate it must be very easy to understand. It must be like plug and play, or maybe so intuitive that don't even have to press a button. And that's the bigger challenge, I would say.
Thank you. Thanks, Prof. Reiner. I believe, Peter, do you have anything else to add on to that?
Yes, I just wanted to add one thing which also needs to be taken care of, which is safety. If we're talking about the home use, one of the main things which we need to take care of, and that's one of the challenges we need to think about, is how do we ensure the safety in an environment where there's possibly no trained staff around. It's easier. One of the reasons for using it in the hospitals is because there's always someone who is medically trained and is generally intended to be used for by people who have some health problems. While at home, there's basically no control. And so apart from that, yes, I think there is a big gap in understanding so far that it needs to be funded somehow by insurance companies, but they need to be sure that it's doing profit for the patients. So we're sort of stuck in between. We can't start offering it until it's widely accepted, and it's not widely accepted until it's known to help. So there's a lot to do in terms of clinical trials and practices. So yeah, let's try to do that.
Yeah, I totally agree with Peter. What ReWalk has done is that before the individual can purchase the personal exoskeleton, the user, the potential user, has to undergo 3 to 6 months of intensive training with the therapist to ensure that they know how to operate it, as well as the carer knows how to operate, to ensure safety, which I think Peter has nicely emphasized again and again, that once it's out in the home, there's no so-called oversight from the clinician. Hence, the carer plays a critical role in ensuring their safety. Thanks.
Maybe let's finish up with the last question over here by in the Q&A box. This is towards Professor Reiner. Okay, could you talk about the promised future of the application of EEG, BCI, and EMG in exoskeletons in practice?
Yes, very good question. On the one hand side, electrophysiological signals are an important source of information about motion intention, which are otherwise maybe not so easy to transfer to the device, because the device are controlled with motors usually, and the device have to know what the user wants to do. But not always EEG, for example, as basis of a BCI, a brain-computer interface, is not the optimum solution. Although I appreciate all the work we do also in my lab, but also I saw the pictures from Professor Kwee. BCIs are great, have great future, I would say, but often the technology is not yet ready to be applied on a daily clinical basis, because they're not reliable enough. And the signal take a while. You need to calibrate the systems, and the detection is rather slow if you have more complex information to detect them. And just to control the device, you don't need too much information, but it must be quite reliable. If I want to start my movement, it should start. If I want to stop my movement before there's a stair, the device must understand that I want to step it to stop. Otherwise, I'll fall down the stairs. And sometimes this can be solved simpler with simpler solutions, maybe with detection of eye movement or lip movement or any kind of muscles which I don't need for locomotion. That's also another kind. That's also brain-computer interface, just not extracting signals from the brain, but from outside the brain. And often these simpler solutions are getting forgotten.
Thank you, Professor Reiner. I think the time is almost up for everyone. Okay, so I would like to everyone to type your questions into the email that we just sent out in the chat box. All right, I want to thank you all for being here and our audiences for joining us today. We would like to apologize for any technical issues and thanks the audience for staying back with us even when it overrun. Okay, so next week we have another webinar lined up. The title is Hand Robotic from Engineers to Clinicians. Joining us will be Dr. Oliver Lambercy from ETH Zurich, Professor Kenneth Nai Kwai Fong from Hong Kong Polytechnic University, and Ms. Jane Wang, who is a CEO and a co-founder of Rosesso Technologies. Please register them online. For now, goodbye, stay safe, and we look forward to seeing you all next week. Thank you, everyone.
Yeah. Thanks, everyone.
Thanks, everyone, for being here.
Bye-bye, everyone. Thank you.
Thank you. Bye-bye.
Bye-bye. Take care.